Okay, thank you. We are almost there. We're going to close out strong. So this is not the School of Sitting. This is the School of Public Health. I'd like everybody to stand up, have one stretch. Folks in the back, you can't ask a question from the back. Come forward. There's plenty of empty seats. As I said, let's close out strong, be part of the conversation. I welcome you to the front. Okay, with that, as Sandra said, I am Katharine Lusk. I'm the Executive Director of the BU Initiative on Cities. It's a real pleasure to be co-host to the event. It's also a pleasure to close out the day with a panel discussion on the past, present, and future of cities. What are we really going to talk about? We're actually going to talk about how we take the wealth of knowledge, sort of what we know about challenges and issues and solutions, and how do we move to action and impact. I'm going to take some moderator's privilege and share two things about the Initiative on Cities. One is that we actually look at cities from a multidimensional perspective. We are unique in that we are a research center that draws on the full bench strength of BU, everyone here that's interested in cities and urban populations. So we care about every discipline's perspective and how they solve urban challenges. Second, we spent a lot of time talking to mayors. I wasn't going to do this, but I couldn't resist because so many of the issues that we've covered in an annual project we run called the Menino Survey of Mayors, so many issues that you've all touched on today are ones that we have asked mayors about. So every summer we do live interviews with over 100 US mayors across the country, cities over 75,000, and we publish the results every January. A few tidbits that you might find interesting. Housing. Huge national concern. This is not a coastal elite issue. This is a widespread challenge that mayors across the country say they're facing. 13% of mayors believe that their current housing stock is well matched to the needs of their residents. And they also believe that housing costs are the #1 reason that people are moving away from their cities. Number 2, bikes. They love bikes. Who knew, right? 70% of mayors actually support expansion of bike infrastructure, even if it comes at the expansion of parking and roadways. Number 3, if they received a big capital grant, where would they put it? Mass transit. If they received a small capital grant, where would they put it? Bike and pedestrian access. Poverty. They are very focused on poverty. We ask mayors, do you care about income inequality, poverty, or the shrinking middle class? Overwhelmingly, it's poverty. Who's the most marginalized in your community? Those living in poverty. Who do you believe you should be doing more to help? Those living in poverty. They're very concerned about their communities and their residents that are at the lowest end of the income spectrum. 84%, this is one of my favorites, 84% of mayors believe that climate change is caused by human activities. That compares to about two-thirds of the general public in this country. They are allies as Pat pointed out, they are allies in tackling climate change, and over 2/3 of them are willing to pay, sort of accrue the cost of actually mitigating and adapting to climate change. For the first time this year, we've actually asked them about their perceptions of public health challenges in their communities and the health issues for which they believe constituents hold them accountable, right? The ones that they think voters care about. And those results are going to be coming out in January, so I'm not going to reveal them here. We talk about the Menino survey as being a survey of perceptions and priorities, right? Sometimes it's a measure of political will, but not always. We hope it's sort of a precursor to political will. But it's also a measure of misperceptions, and it's a measure of knowledge gaps and knowledge deficits. And I think Agis is going to touch on this when we talk about sort of literacy and health literacy. So we've asked mayors a number of questions related to racism and discrimination. Overwhelmingly, they recognize that racism and discrimination exists in this country, it exists in their cities, and they're very easily able to articulate the groups they believe are most discriminated against. But they don't perceive discrimination in the quality of the built environment. To me, that's a major knowledge gap. So we've talked a lot about neighborhoods. We've talked a lot about spatial inequality. This, to me, presents itself as a huge opportunity. So when you ask them to talk about the quality of parks, roads, and transit in neighborhoods, in white neighborhoods compared to neighborhoods of color, they believe they're equal. So in an area that they control the money and the dollars, they don't actually perceive problems. We think that that's a huge opportunity, again, and a huge knowledge gap. You guys like frameworks, so I'm going to close with a really quick framework. Overall, when we talk to mayors about the things that they're most concerned about, there are 3 legs of the stool of what makes a healthy and vibrant and productive community. physical infrastructure, right? Robust physical infrastructure. Good transit that runs on time, good roads, good bridges, good schools, good buildings, good utilities. Economic infrastructure. That's both the economy, that's personal savings, but it's also the fiscal health of the city itself. Does it have the money it needs from its own sources and other levels of government to pay for the things that are important to that community? The third is social infrastructure, right? So you need the physical infrastructure, you need the economy to be working, you need the city to have money to pay for the things, and then people. Are people healthy? Are they happy? Are they educated? Do they get along with each other, right? These are really simple premises. So when we talk to mayors, and I think it's now up to, I don't know, over 600 interviews we've done with folks over the last 5 years, those are the themes we hear. And what's heartwarming for me is that they speak your language. They're on your side. They're convinced in many, but not all, of the things that you are all talking about. So where is this panel going? This panel is going to talk about, again, how we get from action to impact. And we're going to talk about how we get levels of government working together, how we get government and community working together, and how collectively we, and as allies also in the public health community, can actually come together to overcome some key challenges to implementation and impact. So I'm joined by Sabrina. She told me to say Hermosilla. No, Hermosilla. Hermosilla. I wanted to say Hermosilla. Renée Boynton-Jarrett. Where's Renée? I don't see you, Renée. There's Renée. Thank you. Renée Boynton-Jarrett. David Siscovick, who's right here, and Agis Tsouros. And I'm going to invite them up here one at a time. And then make sure, don't go back there, Renée, make sure that you're readily accessible so we can take the stage quickly. Thank you so much.
I've also been looking forward to the green button. And before I start, I'm going to take presenter privilege. And actually, it's Chilean Spanish that has the best accent. So and so it is Hermosilla in Spanish, but I say Hermosilla in English. So anyway, my name is Sabrina Hermosilla. The chapter that I'm going to speak to you about today has to do with migration. And before I get started, I want to also thank my co-author, who's also here, Tahila Rebello. All right, so let's get started with a bit of definition. So the freedom of movement is actually a fundamental human right. It was codified in the Universal Declaration of Human Rights in 1948. So this is something that is part and parcel for our discussion. And when we talk about migration, our functional definition here is the movement of a person or group of persons from their initial area of residence, or you can think of it as a home community or home country of origin, to a new geographical location known as a destination community. Sometimes you might hear things like receiving or host community. These are all sort of similar concepts. And here we're explicitly talking about both internal, so individuals and groups who have not crossed international geopolitical lines, and those who have. So it's important to start with that. Since the title of this panel is Past, Present, Future, I think it's important to start with the past. So one or two people have actually, especially in the afternoon, explicitly mentioned migrants, but migration has been central since the beginning of history in the creation of urban centers. And I think I'm really glad that we have a chapter on this to explicitly recognize that. So present, we hear a lot about international migration and global cities. One of the largest challenges to this work is this issue of disparate data and different data sources that other individuals have talked about. But I'm going to try to give you a snapshot of what it looks like now. So there's about 984 million migrants presently. Most of this comes from the IOM, the International Organization of Migration. About a little less than a third of those are international migrants, and then over 2/3 are domestic migrants, so they've migrated within their country. This translates to about over 3 million people moving into cities every week, which is really important. And then when we think about globally international migrants, the two global cities that have the largest percentage of foreign-born population are Dubai and Brussels at 83% and 62% each. So let's look at this a little bit more from a global perspective. So in our chapter, we wanted to look a little bit more closely at the countries that had the highest percentage of foreign-born population. So the first one is the United Arab Emirates, UAE, and they had 88.4% of their population was foreign-born in 2017. This figure shows the rest of the countries on a global level. And if you're trying, it's a little small to fit all of those in, but if you're looking for the country we're currently standing in, it's not there. So the United States percentage is around 14. But again, this is a percentage of the population. If we had chosen to make this figure on just crude absolute number of foreign-born populations, then actually, yes, the United States would be number one. But this is also a talk about urban health. So we wanted to interlay this. What in these countries, what is their population of urban health, the urban-rural divide? And so again, let's start at UAE. The dark blue is the urban percentage. And so in 2017, about 86% of the population in the UAE was urban. And so we've heard earlier projections about, we're going to hit 60% in 2050. Well, all of these countries, essentially save one, are already there and above. And these are also the countries that have the highest percentage of international migrants. So we did a little bit of the past, present, and now we want to think about the future. And it's our contention in this chapter that migrants present both diverse needs, but also really unique assets. And if we're going to continue and build and improve healthy urban spaces, they need to be incorporated and included therein. But so we wanted to unpack briefly just some of those barriers and how they can be translated into opportunities. First, we explored the health services and systems area. And so many speakers have spoken about barriers to accessing care with respect to migrants. You may think about this from a linguistic perspective, a cultural, a legal perspective if people don't have the appropriate status, but it's many issues that are that exist in urban centers anyway. We also think about vulnerable subsets in urban spaces. So migrants often go through unique challenges in their migration process. So we heard a little bit in the Macau talk about that. And so they might have unique needs upon arrival. But we also don't want to just get access to services, right? We want to have improved and effective services. So a lot of work with migrant health has to do with that it's linguistically accessible, that it's culturally relevant, that people feel comfortable. But if I didn't use the word migrant in the beginning of that, you would say, don't we all want access to effective health service as such? And then some of our challenges has to do with migrant health outcome tracking, who's collecting the data and what does it say. And then really the way that we move this forward is through multi-sectoral approaches that I'll give you one quick example on in a moment. The other two main areas we talked about, one is context matters, and I was really excited that we got to go after the case study panel. So right now, you may be thinking migration, everybody's coming into urban centers are growing. Well, actually in the United States, 10% of urban centers are actually shrinking. So this is really a diverse and challenging issue. And then finally, governance and policy. And so essentially saying that we have the opportunity if local governance, if national governments can work together to have healthy policy for migrants. I sort of say it like that because that's a little bit idealistic, but I'm not going to detail all the examples of where that has failed us. So, quick example of a situation where people are making positive progress is the Johannesburg Migrant Health Forum. This is in Johannesburg, South Africa. And so about the time that this was established, about 30% of the population was domestic migrant and about 13% were international. And so this was a very high migrant population. And the main pull factors, the main reasons why people were coming to Johannesburg were because of increased economic opportunities and security. And while this is an example about Johannesburg, you'll hear this repeated in many different contexts. And so in 2008, the IOM, International Organization of Migration, and universities and NGOs came together to essentially try to improve the migrant health in this one densely populated community. And what they've been seeking to do is to first actively monitor anti-migrant discrimination, and they're doing that in the public sector. Then linking community members with policymakers in a live fashion. And then finally, facilitating collaboration between service providers and NGOs, specifically focusing on migrant health. Now, this is, while established in 2008, they're still building the evidence base for this, so I'm excited to see what further work comes from there. So, we came to the end. What do I want you to remember besides Chilean Spanish is awesome? First, migrants are central to urban spaces. Migrant issues and challenges provide us a unique opportunity. It, especially, so my work focuses in more forced migration contexts, but when you have these migration flows, you get the lens for the good and the bad of the CNN, and sometimes you get increased access to resources. And if we can leverage that with our communities, we can affect positive change. And that can only be done through creative, multi-sectoral approaches. Thank you.
Thank you to the group who's here at the end of the day and for your amazing questions throughout the day. Thanks to the esteemed panelists and presenters from earlier today, and of course the excellent team that brought this anthology together. I'm going to talk a little bit about the emphasis on urban health from the perspective of children and adolescents. And I want to begin with 3 historical facts. So we know historically, and it's been well established throughout today, that periods of rapid urbanization pose challenges to population health, and the urban context in and of itself poses unique challenges to population health. But I don't think what we haven't emphasized as of yet is that this means that children and young people are disparately affected. Why is that? Well, children, by 2025, 6 years from now, 6 of 10 children in the world will be living in cities. By 2030, the majority of residents of urban environments will be children. So children compile the largest population of stakeholders within the urban cities that we are concerned of. The second fact, historically, and I think it's been emphasized beautifully by the diversity of presenters today, is that while the fields of population health and public health and the field of urban planning, historically, if we look back, really emerged from very similar strivings. Disease, infection, ways to contain and control that, they evolved in parallel, not aligned, not interconnected, and not dependent upon each other. And so some of the threats that rapid urbanization posed to population health exist because of this parallel evolution of fields that truly could, if aligned and coordinated, could benefit to work towards the same goals. So the third historical fact is that, truth be told, when we think about urban planning and design, children are not considered a beneficiary. They are considered a complication and maybe a nuisance factor. So if we look at historically how urban planning has considered children, the heavy emphasis has been on safety and how to help caregivers manage the safety, so traffic patterns, making sure kids don't get hit by cars, X, Y, and Z, safe parks and playgrounds. But also that emphasis around safety has also really restricted the way in which children can participate in recreational activities within their environment, and connects to a lot of the other health challenges that have been well emphasized throughout this morning. So if we just were to, I don't want to rehash what's already been said around the real interdependence between the built environment and factors such as physical disorder and blight and the social environment. So, but how this shows up to impact child health is unique in some respects. So if we take the example of slums, so 1/3 of urban populations live within slums, so a large number of children live within slums. As was emphasized earlier this morning by Dr. Suglia, with children, we have to think about developmental age and stage. So infant mortality rates are higher in slums. There are additional risks to child health in certain types of urban environments. We also have to think about gender differences. Risk for illiteracy, malnutrition, early marriage, early pregnancy, sexual trafficking are all higher for girls that live in slums. So there are unique features of your urban environments and particularly disadvantaged, concentrated disadvantaged areas in urban environments that have different risk patterns and trends for children. And we do have to pay attention to that. So currently we're having a bit of a renaissance period, right? A lot of what we've talked about today you will see on NPR and popular media. Social determinants of health are there. And there's a renaissance around the importance and understanding of the impact of where you live, learn, and play. The ecosystem wherein your health develops has on your life course health outcomes, and it's motivating changes in our work. I think this symposium, this book, the work that people are doing are examples of these emerging strivings. So we're now pushing against this language. The language of livable and healthy cities is wonderful, but now entering the fray is the concept of child-centered communities, right? And child-friendly cities. And so historically looking back, if you think about Article 31 from the United Nations Convention on the Rights of the Child, in that language, the right for children to engage in play and recreational activities is there. So that's way, 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 way back. How have we activated on that? Now, most recently, in the 2016 Habitat 3 conference held by the United Nations, the idea that safe, healthy, livable, secure environments for children as well as adults was specified, as well as a commitment for children to participate in the decision-making process, which is another piece we haven't yet really talked about today. So as we think about that, I'd like to just briefly suggest 3 emerging strategies, right? And so the first has already been talked about a lot, multidisciplinary approaches. And I can only emphasize the importance of that in building on what has already been shared by colleagues. But when we think about this from a child-centered approach, green space, traffic volume, residential density, use of land mix, traffic speed are all intersecting variables for the built as well as the social environment. We have to think about the perception, perspectives, and opportunities for social connection for children in these efforts. As we think about systems level, multi-level research agendas, we have to think not just about the relationship between the built and the social environment, but how macro level, macro environments, food and agricultural policies, food marketing, social norms are targeted towards children and how they influence the opportunities for health and well-being for children in different ways. And then finally, as we talk about community engagement, we really have to think about where's the role and voice and participation of children in those strategies. And there's already evidence that children participating in child-friendly initiatives is an essential and core strategy to that work. And then finally, as we think about policy implications, it's very important as we push for higher levels of precision in our multi-level and multi-sector analyses that we don't forget adjacency. Disadvantaged urban communities are not created in isolation. They are created in relation to the communities that are benefiting, that are adjacent to them, whether it is a suburban environment or a more advantaged urban environment. So we absolutely miss an opportunity to truly understand the fulcrum of change and historical processes, redlining, residential segregation, classism, linguistic and cultural injustice, that created not just the disadvantaged urban environment, but the adjacent environments. Thank you.
Sorry, just a quick announcement. We're actually living urban health right now. Some of you who are hooked into emergency system have received rather alarming messages on your phone. It's fine. There was a fire outside the building, which triggered a fire alarm in an adjacent building, which triggered the elevators being shut down, which triggered multiple messages. So the net effect is, if you have to leave in the next 5 minutes, you'd have to walk down 14 flights of stairs. So they told me the elevator should be fine by the time we finish the meeting. So I just want to reassure everybody. We actually have a chapter in the book on disasters, but the speaker couldn't come today. So it's a real life thing. David, over to you. Sorry about that.
I hope you're not saying that the next speaker is a disaster. And I do appreciate you keeping everybody in the room for the next 7 minutes. And if someone's colorblind, they're not going to be able to see the big green button. So the school should change that. Can we go back one slide? There you go. Okay. So as indicated here, I'm a physician, scientist, internist, cardiovascular epidemiologist, and I left the Pacific Northwest, went to New York City in 2014, and within a year and a half, I found myself interacting with urban planners, and not just any group of urban planners, but an incredible group of urban planners, architects, experts in transportation, housing, energy, climate change, et cetera, et cetera. And I was somewhat of a fly on the wall, but I was a persistent fly. So I attended a lot of meetings, roundtables, seminars, community engagement efforts, et cetera, to learn as much as I could. And when given the opportunity to contribute a health perspective to a huge effort that was ongoing that I'm going to describe. I'm going to talk about reconnecting regional planning and health, and I'm going to specifically summarize some of the activities of the 4th Regional Plan for Metropolitan New York City. Let me just basically give you a little bit of the history. Since 1922, the Regional Plan Association of Metropolitan New York has basically been a de facto regional planning agency for the tri-state region of Connecticut, New York, and New Jersey. It's an independent, nonprofit, civic organization. It is non-governmental. It basically is a organization that does research, planning, advocacy, and public engagement. It identifies the major challenges to the region. It is forward-looking over the next generation, that is about 25 years, and it tries to identify potential solutions. As a result, it shares ideas and plans with policymakers and with decision makers and so on. It has no formal standing. Its only strength is in the strength of the research and the outreach that it conducts in developing its plans and recommendations. And when I say that it tries to inform decision makers, that's at all levels of government, whether it's the federal, state, city, town, county, et cetera, et cetera. And then what it does between plans is it advocates for implementation. So if we could go to the next slide. Do I do that? Okay, so the first regional plan for Metropolitan New York was developed by the RPA and released in 1929. It focused on something we've talked a lot about today, cars. In 1968, the second regional plan was released, and that focused on people moving from urban settings to suburban settings. In 1996, the third regional plan was released, and that focused on some of the challenges related to transit. The third plan mentioned equity a little bit, but it wasn't a major focus. Health was not included in the second or third plan. It was actually explicitly mentioned by the president of the RPA in the 1929 plan, because at that time there were still issues with regard to sanitation and the environment and its impact on health. One of the things I wanted to point out is the Metropolitan New York region, for those who don't know, goes from New Haven, Connecticut to Trenton, New Jersey. It includes 23 million people. It includes 783 municipalities. One of the municipalities is New York City. It includes 10% of the US economy. It includes 3,700 miles of coastal region, and each of the three states have wetlands. And so it's a somewhat, and it also covers urban, suburban, and rural areas, including the Hudson Valley in New York. So it's a incredible task to try to think about urban planning for the next generation around such a complex region. One of the reasons it makes sense to do it at the regional level is that the three areas in the region, or the multiple areas, share many common issues with regard to transportation, housing, the economy, et cetera, et cetera. Okay. So in 2012, the president and the board of the RPA decided to consider whether to launch an effort for a fourth regional plan. And some of the drivers that motivated them to do that was the fact that in the following years of the recession of 2008, there was differences in sort of the ability of different subsets of the population to recover. In addition, in 2012, we had Hurricane Sandy, which had devastating effects on Lower Manhattan and other parts of the city, as well as other parts of the East Coast. And the third issue had to do with infrastructure that was thought to be crumbling and was a major challenge that had to be addressed. So just to summarize, excuse me, could I go back one? Okay, so these are these four slides basically set the stage, if you will, in 2012. It was thought that opportunities, economic opportunities, other opportunities, were limited for too many people. That was one of the motivations. The second point was there's a rising crisis of affordability. This is in 2012, we're now in 2018. No one's denying that there's a rising crisis of affordability. We've heard about that today. The third point was that the region was vulnerable to disasters. And there was a sense that something had to be done so that the region would be in a better position when the next natural disaster occurred. And the fourth point was that it was commonly viewed that the government institutions that existed were failing to make the hard decisions that needed to be made to address the major infrastructure problems and other problems of the region. So that led the Regional Planning Association to basically come up with this visual of 4 goals for the fourth regional plan. Create a dynamic customer-oriented transportation system, make the region affordable for everyone, rise to the challenge of climate change, and fix the institutions that are failing us. One thing that you'll notice is that health is not mentioned. Equity is not mentioned. In 2012, the Regional Plan Association was doing what it does. It was doing urban planning. Then what happened was they were given a small grant by the Robert Wood Johnson Foundation. And as you'll see on the bottom right, left-hand corner of this first page, of a white paper that Karen Lee and I were involved in providing technical assistance on, called The State of the Region's Health, or How the New York Metropolitan Region's Urban Systems Influence Health. And when the RPA staff did this work, they of course looked at health in place. And you can't look at health in place and not notice that there's a huge variation in life expectancy, in morbidity, in quality of life, et cetera, by place. We've talked about that today. And it's whether you're looking at states or whether you're looking at counties or whether you're looking at neighborhoods. In all cases, whether it's contiguous neighborhoods in Manhattan or continuous counties in northern New Jersey or it's continuous towns in southern Connecticut, there are huge disparities in health. And as planners who deal with space, this place and health relationship, I think, could not be denied. And so basically, this white paper was one of the, I think, an important milestone for the RPA to declare that health was an issue that they were going to be addressing in the 4th Regional Plan, which was under development at that time. And so they came up with this, and this was actually in the final plan, and this is what they say today. Our goal is to make the region work for all of us. And these are our 4 guiding values and goals. One is prosperity, one is sustainability. That's been our goal all along. That continues to be our goal. Equity, we began to approach in the 3rd Regional Plan, but not in a serious manner. But now we're going to take on equity and health in addition to prosperity and sustainability. So if you go to RPA web pages, you will see this visual. This is a very strong statement that they are committed to addressing issues of equity and health in planning and long-range planning for a major metropolitan region in the United States. So what they did was they came up with a document that's 374 pages long. It's now coming out in book form, so you can buy the book. You don't have to kill a couple of trees to print out all the pages. And it has over 40 chapters, but it has over 60 recommendations. And of the 60, each of the recommendations, and I have to say I had a chill up my spine when I saw this. Each of the recommendations is basically assessed in terms of its potential impact on those 4 goals of prosperity, sustainability, equity, and health. So those 4 items are listed on the page with each of the major chapters. And there were, of the 60-some recommendations, 20 of them were rated as having a potentially high impact on health. And I broke it down here by the 4 areas that they had said they were going to attack. Rebuild and expand the transit system, here to serve everyone. Create affordable and healthy neighborhoods. You can see there were 5 recommendations that were rated high in terms of health impact. Address climate change by creating a healthier environment and reform institutions to incorporate health into decision-making. And I would say not only to incorporate health, which was suggesting to have a chief health officer for every agency in every city government and state government and so on and so forth, a chief health officer. But also it was to change the whole approach to engaging communities in planning early in the process and throughout the process, which we've heard about today. So they're really, and they engage communities greatly in the development of this 4th Regional Plan. So I've talked about the past. I talked a little bit about the present. The plan was released a year ago, November 30th, 2017. I want to talk a little bit about what they saw in the future, and I'm only going to use a couple of examples from one area, which was transportation. So by 2040, they suggested that 80% of all urban street space should be dedicated to walking, biking, and transit. And they said that if we did this, this is what a street would look like in 2040. They said that the subway, while needing huge changes in terms of infrastructure with regard to signaling and so on and so forth, they don't have elevators in every subway, so it's not accessible to mothers with babies in carriages or to people with disabilities in many cases because of the steps. I was aware of the fact that there's exposure to dust, to pollution, to noise, to heat from the subway, just standing in it. When I go in the subway and I see little children and I think about them being exposed lifelong to these hazards, it really bothers me. So I said, did you consider doing something about reducing those exposures, potentially by having screens? And of course, that's expensive and it may not happen, but this is what the plan included. It included incorporating screens into the subways as a way of reducing some of those exposures. And then this is the last example I'm going to give you. They suggested that new light rail systems were needed to connect people from vulnerable communities with employment opportunities. Right now, if you live in the Bronx, if you live in Queens, if you live in Brooklyn, 3 of the 4 outer boroughs, if you will, from Manhattan, you have to go into Manhattan to go out to the other borough. So your commute is made unnecessarily long because there's no connection between those 3 boroughs. So they suggested something called T-Rex, which would be to use existing rail lines to connect the Bronx, the Queens, and Brooklyn so that people could get to employment opportunities in those 3 boroughs in a more timely fashion. And I'll just point out that they were very proud that commute time in New York City was less than an hour for a third of the population. I pointed out to them for the 2/3 that it's more than an hour, many for whom it's more than an hour and a half. It's a tremendous source of stress and potential adverse health effects. So this is what the Trimax might look like in the future. So I just wanted to say that just as yet another example of the RPA basically getting it, this was one of the phrases in the report. Everyone deserves the opportunity to live the healthiest life possible, regardless of who they are or where they live. And I think that really says a lot about the commitment of this organization, which is not a health organization. It's a planning organization, to integrating health and equity into plans and into their assistance of government in making decisions with regard to investments. Thank you very much.
No green buttons. I will, first of all, I would like to thank Sandro and David for this great opportunity and to contribute to the book, both the experience from Healthy Cities, but also the Healthy Cities movement, but also this idea of leadership, city leadership for health and sustainable development. And I would like to start by coming from another world. I've spent about 30 years working in the World Health Organization. The first project I was given to develop was Healthy Cities from zero. It was 1988. And what was very interesting about it is that in the beginning, we thought that talking about urban health and inviting cities to be part of this will be of interest to maybe a few. We thought of running some kind of a pilot project, but we discovered very quickly that the idea of integrating health in city policies, of putting health high on the social and political agenda of cities was extremely attractive to cities, to city leaders. So within 1 year, there were more than 200 cities that wanted to be part of this. And within 2 years, this idea had spread in the whole world. And where I come from is to explain that there is the world of science, there is the world of politics and political engagement, and the work I was doing and the work we do at WHO you have to also remember that the World Health Organization, like most of the UN organizations, talk to the national level. So it was very unusual. It was quite revolutionary that the European region of WHO established direct links with cities, with city mayors. So what was the real challenge was to broker all these ideas, to bring the science, to integrate health, not in terms of a series of interventions in a number of areas, but to really make health a core value in city development, in city strategies. So, and I want to give you some examples when I listen to colleagues, and this morning you may have heard me talking about intellectualization of some of these issues. I give you a simple example, which to me is a case study that we all learn a lot from. In 1998, I went to Michael Marmot, who was already a very well-known scientist for his research on social determinants. And I said to him, I have a feeling that this bulk of evidence that you have developed is probably very attractive and interesting to discuss in public health fora, but our job is to bring this very interesting knowledge to those who can do something about it. So in 1998, we developed a publication which some of you may have seen, which is called The Solid Facts, the Social Determinants of Health. It was a very brief publication which was addressing the key messages for policymakers, and it was very brief. It was about 45 pages. This publication was republished in 2003. What is very interesting? For 20 years, this booklet is on the top list of bestsellers of the entire WHO organization. Do you know how much it cost me to produce this when I went to Michael Marmot? $2,000. And it's still, for 20 years, at that level. Do you know how many millions have been spent since then on research relating to the social determinants? Absolutely valuable research. But very often this research doesn't reach those who is supposed to be addressing. I have said very often to Michael that with the money we have spent afterwards, these publications will have to be on the top list for another century to justify the expense. So the other issue that I want to share with you is I thought in the beginning when we started, and equity was one of the top goals, that if we had more evidence, there would be more action. Because in those days, in the 80s, it was, for many people, very ideological to talk about equity. It was more left-wing, socialist, and so on. I can tell you today, we are drowning in evidence, but still, action is very limited. And I come from Europe, and you will see, yes, the usual suspects. Finland, Sweden, Norway, Denmark, Holland, the UK, maybe the Netherlands, and a little bit in France. But what is it? You know, I travel the world. Do you know how many times today, in this century, I am met at the airport by city or government officials who will say to me, Dr. Tsouros, please be careful. There are two terms you're not supposed to be using, the term equity and the term poverty. Find other ways to describe differences or whatever, but these are no-nos. And one of the issues that I want to really stress to ourselves is that when we engage now with our partners out there, we have to realize that the long list of modern approaches to public health, to address the public health challenges of the 21st century, require whole-of-government approaches. The health sector alone cannot do it. But you know what's the good news? If you come to Europe today, you will find that while in the beginning of the movement, Healthy Cities was invariably based in health departments, well, hello, today there are many departments which are planning departments. They are architects who lead healthy cities. They are not cardiologists or even public health doctors. The idea that today health is an integral part of social, human, sustainable development. Now, for us, I mean, I can show you a lot of publications. This is the Belfast Charter for Healthy Cities. This is the almighty acclamation of mayors. These are all hot off the press. There is a lot of political statements which I have to tell you are very important in creating legitimacy and commitment for action. If you're trying to use just a scientific entry road alone, it doesn't work. You really need commitments at the highest possible level. You need partnerships. You need to broker the ideas and explain them. I mean, to explain what is a life course approach, what is a population-based approach, what is community resilience, what is health literacy, what is to address the gradient of social determinants. Because let's face it, today everybody is smart. You can Google up any city, modern city in the world, you can copy-paste some of the fancy talk, you can put it in the preamble of your publication, and you're modern. For me, what is important is not what you say you want to do as priorities, but how. Because most people think that equity equals only access to health services, or only dealing with some vulnerable groups. There is a lot of that. There is such a waste of precious concepts by many. They pretend they are doing it, but they are not. Now, what is new now, and I think we have to take advantage of that, is the fact that the Sustainable Development Agenda, which, remember, is not an agenda like the Millennium Goals, which only concerned developing countries. The Sustainable Development Agenda is a whole of the world agenda. And it is highly relevant to the city level, to the local level. And that gives us enormous legitimacy to basically create mechanisms, true mechanisms, because, colleagues, we keep talking to each other, we keep giving standing ovations to each other, we don't talk to the right people. Our agenda of social determinants and the determinants of health, commercial, political, cultural, is an agenda that should be discussed in political party platforms. This kind of information should shape policies. This is not just to us saying to Michael Marmot, congratulations. We have said that for 25 years. What is important is to take this evidence and say it to the education sector, to the planning sector, to the transport sector, that, hey, maybe we can do it differently, but not really dictating to them, just because we discovered that health is so important, what to do. But it's better to say what health can do for you and what you can do for health, creating partnerships with a shared understanding. I want to finish with a couple of examples. Often we're talking about implementing the social determinants of health. And we talk about the upstream and the downstream, and some people are totally confused. For me, the best thing to do is, instead of talking about structures and silos and the usual talk, I can give you publications published in WHO, which I discovered on dusty shelves from 1986, which if you just put some white stuff, what is it called, on the date, they would be as relevant today as ever. My recommendation, and what I have seen actually being used today, is to take some of these global strategies and convert them into goals which will necessarily involve around the table different sectors with shared accountability. If, as a city, for me it's the noblest goal you can set, giving every child in the city a healthy start in life, which would involve at least 7 to 8 sectors, that under the leadership not of the health sector, of the mayor, of the partnership, that let's do it. Let's set a time frame that could actually create the outcomes that we want to do and could have and could genuinely put health at the core of city strategies today. So I know that David is looking at me. You didn't show the 2 minutes to the previous speaker, so I didn't see you doing that. So, yes. And this was, and so because health is a political choice, I think it is the leaders, and leadership is so important, who will have to say, what sort of society do we want? We have to be explicit about this. Do we want to create cities for all? What are the strategic approaches that will deliver better dividends in terms of health outcomes? And what is the organization we have to put in place to make it happen? Thank you very much.
Yes. I'm going to ask the first one. Sorry, I'm really going to do it because it's the end of the day and we want to put a fine point on things. I loved, David, you gave me my question, which is you had the point up there about how do we reform institutions to incorporate health in decision-making. To me, that's what this is about. That's what this panel is about. That's what this day is about. How do we reform institutions to incorporate health, ideally health, equity, sustainability, and prosperity, but we'll stick with health, in decision-making. I'll tell you what I heard. I heard today community pressure. We arm the community with better information. We treat them as assets. We respect their perspective. And we give them the tools to advocate with public officials. I heard direct engagement. As public health experts, get a seat, whether you're elbowing your way in, get a seat at the table and be a trusted advisor to various levels of government so that they respect your voice and your opinion and you're able to actually be part of decision making. I heard badges and recognition, right? That matters to politicians. Am I doing something well? Well, sometimes badges, right, if they're evidence-based badges, sometimes those badges are things that they herald and they say, look how well I'm doing. But we also heard about badges as an educational tool, as a mechanism to say, here's where you're failing, and here's how you compare to your peer group. And I also heard about education. I heard about educating government, educating stakeholders, but part of education is this translation, right? So how do we actually take this wealth of knowledge and translate it into a language that is making it accessible and actionable to government? So those are a few things that I heard. And I'm curious, I want each of you to very quickly reflect on, and then we'll take a couple questions from the audience. I want you to each to very quickly reflect on this question. In your experience, how do we reform institutions to incorporate health in decision making? Who wants to go first? Really quickly, because we do not have a lot of time.
Yeah, earlier today, Helen Pinillo, did I pronounce that correctly? I don't know if she's still here, who's an urban planner from University of London, basically said that health people need to be responsive when asked by planners and others to provide input. And that's exactly what Karen and I did. And in terms of sticking with them, I basically showed up at as many meetings as I could, whether it was about transit, housing, or whatever. You know, I'm not an expert on any of this, but I had to learn about it, and I wanted to make sure health was represented. And by showing up, that did that. And I think I continue to show up. If I reach out to them and say, you know, you're going to do something about NYCHA, I want to be involved. New York City Housing Authority and its risk to children. So,
great example. Others?
What we found very, very useful in more recent years is to add well-being to health. health and well-being is increasingly now used also in the global WHO strategies. This is also more attractive to a wider range of partners who may see health more specific to a sector. But as I said before, health is now an issue that it is squarely on the agenda of local governments, of national governments, and on the global stage. I mean, health is now regularly in the G8, in the most of those fora, because it has been acknowledged that it goes hand in hand with social and sustainable development. So I don't think we have to take much convincing. It is mostly to answer the question to the mayor who says to you, yes, you convinced me, where do I start? And how do I do that? And what do you want me to put in place to begin that process? And one last thing, one of the most popular tools that Healthy Cities in Europe developed is called City Health Profile. That every city was obliged to develop a profile, not only morbidity and mortality, but around the social determinants, the conditions in the city, environmental, social, lifestyles. This was so powerful in not a volume like this, very brief, that was debated in city councils. It was valuable.
I think there were numerous examples shared today that we're starting too late and we're focusing on end outcomes, chronic illness, chronic disease outcomes. So the example of neighborhood revitalization was shared several times, and all of the unintended consequences of neighborhood revitalization to prevent obesity, to prevent chronic disease and heart disease, that then causes development that leads to profound displacement and profound reinstating of inequity. So we have to really begin by thinking about health promotion, and if we're going to embed health in policies and systems levels, we can't think about end outcomes of health alone. So we really have to train ourselves to think a little bit more differently, and to also think about the socio-political forces and factors that are really not emerging out of nowhere. They're emerging out of our mental models and ways of thinking about equity.
We have that look. Sabrina has the last word.
She can have the last word.
Okay.
Sabrina can have the last
Sabrina
word.
has the last
Okay,
word.
I can say a brief. So I agree with what's been said before, but I also think drawing on the community-based participatory approaches, making sure that all of the voices are in the room from the beginning. I like that the speakers brought up children, so I do a lot of work with children, making sure that they're involved, making sure that it's inclusion and not reactionary.
Sandra.
Please say thank you to the panel. I'm going to ask David to have the last word, but just two very quick things. First, let me start with the mundane. The elevators are still out. So they'll come back out online very soon, I'm told. It's for those of you who are able and willing to walk, you can walk down. Otherwise, everybody else, they'll come back very shortly. It's number one. Number two, I said a lot of thank yous earlier today to people who arranged this, but I just want to say thank you to the audience. I don't know if you counted, there were 38 people who spoke today, and you participated in a conversation with 38 people, which is really quite unusual in academic and public scholarship. So that you all participated in this and stayed here all day is really a testament to, I think, how interesting this topic is. So thank you all for joining us, and David will close us out.
So it is the end of the day, and we really covered a lot. We really did cover a lot. We talked about challenges and opportunities in urban health and some of the newer methods that have come up, and what is it that we can learn and how much deeper can we go. We also talked about the resources that are out there at a number of different levels. How are they best deployed? And we thought this through the case studies from the various cities. And we ended up with thinking about the future. The future is now, but we have to be able to look ahead. As we were going through the day, and as Sandro said with the 38 speakers, I look around, and for me, there are some people for me who at the beginning of my career were my heroes, right? And they're here, and to me, that makes it special for me. There are others whom we've read about each other or we've interacted a little bit, and here we are, we've had this shared experience. For others, they're new colleagues and new friendships that have come together, and that also makes this a very, very special day. The third point I want to make is that this is not only a special year for this conference, but there's some anniversaries that we ought to take note of. One, 30th anniversary of Healthy Cities Euro, and that's quite a accomplishment. It's the 15th anniversary of the International Society for Urban Health, which just had its 15th international conference last week in Kampala. And it's the 20th anniversary of the Journal of Urban Health. And some of you have published there, some of you have read articles, some have sent complaints, I understand that. But if you've got good papers, send them in. Let's have that dialogue. Let's document and let's engage with each other. I think the last point that I want to bring up, now the speakers will understand this, right, is just a comment. And that is, for something like this to happen, you have to have someone with vision, with clarity, a clear eye about strength between people and the people that are in front of you. You need to have somebody who's a team builder, somebody that can then trust people to deliver, facilitate, and then also be an excellent host. And so I think we ought to give Sandra a really big hand for all of that. So we'll stand up. Yeah. So thank you all for coming. Sandra, is there any last parting shot?
The stairs are...
Okay. All right. Safe travels home, and see you all soon.